Hi everyone, welcome back to our journal club. We are tonight just waiting for Dr. Naveed to join us, and let me just see if I can get him on. Oh, there he is. Okay, that's adding him. And oh, hi,
Hi.
how's it going?
Good. Sorry.
Good. Oh, that's okay. I was just about to say that we are about two-thirds of the way through all the MOC articles. So we are just kind of chipping away one by one. And so thank you for doing tonight's article. Um, we we did have Dr. Naveed on a couple weeks ago, and tonight he's presenting an article on anxiety. He's a psychiatrist out of Kansas City. Um, and if you are ready,
Yes, I'm
then
ready.
okay, all right.
Okay, so the title of our article is Association of Panic Disorder, Generalized Anxiety
Mm-hmm.
Disorder, and Benzodiazepine Treatment During Pregnancy with Risk of Adverse Birth Outcomes. So that's what exactly what it is looking for. So panic disorder, generalized anxiety disorder, and benzodiazepine during pregnancy, and how do they affect maternal and neonatal outcome. They did not mention SSRIs here, but they also are looking at association of SSRIs.
Okay.
Study was done by was led by Dr. Kimberly and Yonkers. It was conducted at Yale School of Medicine, so it was collaborated between three departments: Department of Psychiatry, OBGYN, and Department of Epidemiology and Public Health. Um, I'm going to quickly go through abstract because I think I did the exam, so I think, abstract is really important to read. And anyway, so the importance of this article is that, previous evidence regarding anxiety disorders and their relationship to the pregnancy exists from data registries. However, the diagnosis and data registries may not be may not be precise, and there might be a lot of confounding factors which may be affecting, the relationship between these anxiety disorders and pregnancy and neonatal outcomes. So that's why they wanted to do more of a structured assessment. So the objective is to determine the association of panic disorder or generalized anxiety disorder in pregnancy, or medication which are used to treat adverse outcomes in pregnancy and in neonates. So this study was conducted between July 2005 to July 2009. It was published in 2017, though, and they did interviews, and we're going to talk more about scale. They did interviews at before 17th week of pregnancy, at 28 weeks, and then 8 weeks postpartum, plus minus 4 weeks. Uh, and the maternal outcomes were preterm birth, cesarean delivery, and hypertensive diseases of pregnancy. Among neonate, they looked at low birth weight, use of minor respiratory interventions, and use of ventilatory support. Most of the women in this study were average ages 31 years old. Most of them were non-Hispanic, white, about 73.7. About 252 women had generalized anxiety disorder, and 98 were diagnosed with panic disorder. And 67 women were diagnosed with, were taking benzodiazepine, and 293 were taking SSRIs. So what they found out was that maternal benzodiazepine use was associated with cesarean section, low birth weight, and use of ventilatory support. On the other hand, SSRIs were associated with hypertensive disease of pregnancy, preterm birth, and minor respiratory interventions. Gestational age was shortened in both with benzodiazepine and SSRIs, about 3.6 days with benzos and about 1.8 days with SSRIs. There was no relationship of panic disorder or generalized anxiety disorders with adverse outcomes in moms and neonates. Let's talk more about the study in detail. So they give through statistics, panic disorder are present in about 5% of the women during pregnancy, and generalized anxiety disorder is about 10%. As far as previous studies are concerned, we know there is association between major depressive episode and adverse birth outcomes. But there were not good studies to determine the association of anxiety disorders and birth outcomes. So there were some data registries, like we mentioned. In these data registries, panic disorder was associated with small for gestational age babies and preterm infant. And how, as far as any anxiety disorders are concerned, they have some database on medical record review, which was any anxiety disorders were associated with preterm birth and cesarean sections. However, another problem with those studies were that they did not measure the confounding effect of SSRIs and benzodiazepine on those studies. There are studies by itself which shows that SSRIs are associated with preterm birth, low birth weight, minor respiratory problems in neonates. On the other hand, benzodiazepine were associated with preterm birth, preterm babies, low birth weight, and respiratory distress in neonates. So in this study, their goal was to assess maternal and neonatal outcomes, and also determine the effect of the medications and anxiety disorders while removing the effect of the confounding factors. So that's what they did in analysis. Their hypothesis was, and I'm going to read it because there are a lot of terms. So panic disorders, they said that will be associated with preterm birth and low birth weight. And they said that benzodiazepine will be associated with high risk of preterm birth, cesarean section, and neonatal ventilatory support. SSRIs would be associated with cesarean delivery and hypertensive pregnancies. So what they in this study, they recruited pregnant women from private practices in New Haven, Connecticut area. And this study was conducted between July 2005 to July 2009. And the verbal consent was obtained. Inclusion criteria was age age more than 18, and they excluded any pregnancy which did not which have not, they included any pregnancies which have not reached 17 weeks of pregnancy. So if it was in later stage, they excluded those women. Women with multi-fetal pregnancy history, women on diabetes, because we know, and women who were taking insulin for diabetes, because we know diabetes can have adverse maternal and neonatal outcomes. Women who didn't speak English, did not have telephone, or who were planning to terminate pregnancies, they were excluded. So the aim of this study was, considering the aim of the study, they included women with history of major depressive disorder and trauma history, or patients who were taking treatment. They invited them to participate in the study. And like I mentioned previously, the first interview was done at 17th weeks. Before 17th weeks, then second was done 28 weeks plus minus 4, and third one was done 8 weeks postpartum plus minus 4 weeks. And if just to provide treatment to everyone, if any patients would need treatment, they referred them. If anyone needed any emergency services, they also referred them. One limitation of this study was that, and I'm mentioning it here, that they trained certain layman interviewers. They kind of practiced with them, they reviewed them, and they gave feedback. So that was one of the limitations of the study. Exposure and outcome measures. So they use World Mental Health Composite International Diagnostic Review. version 2.1, which is a reliable and validated tool to be used, and they were conducted through the telephones. Another scale which they used was mini international neuropsychiatric interviews, and third one was Dembra postnatal depression scale. So these were different assessment tools which they used, and we also talked about the timelines. And then for the purpose of clarity, they defined certain things. Okay, if this outcome will be there, what will mean that that when they need to say it's a low birth weight. So a pregnancy was called preterm if it was preterm birth was called when it happened before 36 weeks of gestation. Low birth weight if baby had a weight of less than 2,500 grams. Minor and hypertensive disease of pregnancy was any hypertension which happened after 28 weeks of pregnancy. And then because they were studying minor respiratory interventions, so anything which required suction, tracheal suction, delayed suction or tracheal suction, and oxygen, they called it minor respiratory interventions. Ventilatory support was more, if they required continuous positive airway pressure or a ventilator. That's what they called as ventilatory support. Confounding variables in this, they obtain history about mom's age, race, substance use. So, for example, heavy alcohol use, it was defined 4 or more drinks per week and 3 or more drinks in one sitting. That's what they, if they were screened, they were called positive for history of alcohol use. And then age was categorized. Other confounding factors were like history of medical complications, like history of asthma, hyperemesis, hyperthyroidism, and pre-existing hypertension, and any data regarding maternal illnesses was also recorded. As far as statistical analysis is concerned, I think for us, from psychiatrist standpoint, we just need to know that when they were analyzing the data, they use unadjusted models and adjusted models. So with adjusted models, they were able to remove the confounding factors, like if to determine the association between panic disorder and adverse maternal or neonatal outcome. So they were able to remove the effect of SSRIs or benzodiazepine from that. So I'm not going to spend a lot of time on that. As far as results are concerned, they screened about 9,500 women, and they invited them to participate. About 3,500 women were screened in, and they invited them. Then 2,793 women were selected, but only we talked about that they ruled out any previous pregnancies where there was a multi-fetal pregnancy. So about 2,654 women were included in this analysis. And I talked previously while talking about abstract of 98 of these women had anxiety disorders, and GAD was present in 252 women. Rates were highest in first trimester for panic disorders and generalized anxiety disorders. Another difference here was that they used only, so usually, in clinical practice, we use 6-month criteria to diagnose panic disorder and generalized anxiety disorder. Here, they used 1 month because the length of follow-up was short. That was one reason. And they also said that, the patients with 1 month history of generalized anxiety disorder, panic disorder, has as much impairment as patients with history of 6 months. So I think that was interesting to know. Another thing which, when they, looked at the benzodiazepine treatment and SSRI treatment along different trimesters, 67 women were using benzodiazepine, but 56 used in first trimester, 15 in second, and 11 in third trimester. So in third trimester, they kind of tend to they titrated or they took those patients off benzos. And similar pattern was observed in SSRIs, not that much, but 257 women used SSRIs in first trimester, 157 in second trimester, and at 147 in third trimester. And we know that SSRIs have risk of more side effects when they're used in last trimester or pregnancy. Um, Participant characteristics, we talked about age, 30.1, I think, was the mean age, and most of the women were in category of 25 to 34 years old. Most of them were non-Hispanic white, and didn't look for that, but they also looked at patients with multiple psychiatric conditions. But in the table we're going to review, it talks about the effects of different psychiatric conditions and if there was any comorbidity. As far as association with exposure is concerned, let's go to table. So table 1 is mostly about demographics, pregnancy history, substance use history, so kind of your baseline data. In table 2, they look at the pregnancy outcome measures. So if we look at, first let's look at, what are we trying to study here? So in adjusted models, because that's one without the effect of confounding factors. So in adjusted model, in panic disorder, if you look at, the confidence interval. For hypertensive disease of pregnancy, cesarean section, and preterm birth, there was no association. So I think that the simplest rule is if their confidence, lowest value of confidence interval is below 1, then it's not significant. So that's how I remembered it. So panic disorder, if you see a confidence interval lower value is less than 1, so it was not significant. Generalized anxiety disorder, if we look at them, they did saw similar association. There was no association between any of the maternal or any maternal outcomes. If we look at PTSD, let's see. In PTSD, you saw a similar pattern, and probably same pattern with MDE, major depressive episode. If we look at benzodiazepine use, and we look at hypertensive disease of pregnancy, confidence interval, lower value is less than 1, so it is not significant. But if we look at cesarean section, odd ratio is 2.45. And then confidence interval is 1.36 to 4.40. So that was significant. So benzodiazepine use for mom is associated with high risk of cesarean section. But none of the other outcomes, maternal outcomes, were associated with benzodiazepine use. As far as SSRI use is concerned, if we look at hypertensive disease of pregnancy, it has odd ratio of 2.82, and lower value of confidence interval is more than 1, so that was significant. SSRI's use is associated with hypertensive diseases of pregnancy. And then last one is preterm birth. So 1.56 is odd ratio, and then confidence interval shows that this is also a maternal outcome which is associated with SSRIs. So just to summarize everything, so panic disorder and generalized anxiety disorder does not have any association with any of the maternal outcomes, looking at table 2. And benzodiazepine use is associated with high risk of cesarean delivery. On the other hand, SSRI's use is associated with hypertensive disease of pregnancy and preterm birth. Now, let's look at the next table, table number 3. If we look at panic disorder in adjusted models for neonatal outcomes, again, we see similar pattern. Odd ratio is 0.72, 1.94, and 1, and confidence interval is not significant. So, and then we see similar pattern for generalized anxiety disorder too. So panic disorder and generalized anxiety disorder are not associated with any adverse maternal or neonatal outcomes. If we look at benzodiazepine use, for low birth weight, benzodiazepine has odds ratio of 3.41. And so it was significantly associated, and same goes for neonatal ventilatory support. However, minor respiratory interventions like suction and oxygen, that was not significantly associated. SSRI use was significantly associated for minor respiratory interventions. Okay, so if I have to summarize everything, I would say, and I think that's what they're going to test on, because that's the purpose of the whole article. So benzodiazepine use in mothers is associated with cesarean section, and in neonates, it is associated with low birth weight and neonatal ventilatory support. SSRI use was associated with preterm birth and hypertensive disease of pregnancy. And for the neonates, it was associated with low birth weight. So, no, not low birth weight, minor respiratory interventions. Sorry. So this was, overall summary of the results. As far as discussions are concerned, one thing which we have found in other studies was that benzodiazepine use in pregnancy is associated with fetal abnormalities. But they also pointed out that most of these studies use benzodiazepine in late trimester of pregnancy. However, the higher use of benzodiazepine, we remember most of them were in first trimester of pregnancy, and numbers significantly went down. Okay, so that's why they think they did not see that many fetal abnormalities. Second thing which they said, which they pointed out, was that there was some growth, low birth weight babies, but we also know that if I point out to my earlier discussion, benzodiazepine gestation is lower by 3.6 days with benzodiazepine, so gestational period. So when they, in a post hoc analysis, when they adjusted the number of the days, the weight was comparable to what is needed for gestational age. So they've said that panic disorder was not associated with growth restriction. It was just that they shortened the gestation period. And next thing was they mostly talked about in discussion. They mostly talked about panic disorder and benzodiazepine. They didn't say much about SSRIs. As far as limitations are concerned, I think one of the limitations which I pointed out earlier, that there was no diagnostic interviews were done by the layman. Substance use in most of the history was obtained by self-report. So there can be some social desirability bias, some recall bias, but it was very good size study, and I think they did a really good job of doing the statistic analysis and making sure that their results are not affected by another factor. So I saw that I was confusing you. Did you have any questions or?
There's one question from one of our members asking, so treatment is associated with different negative outcomes, but not the actual mental disease. And that's how I understood the article. Yes.
Yes, that's right. That's right.
Yeah.
And I think let me say something from. So, I mean, in this article, they didn't say that you should not use them.
Right.
I think the most important thing is you watch for the side effects of medications and watch for those things, but they didn't say that you cannot use medications. I think the most important thing for me for myself to take home message is be careful about their use in last trimester of pregnancy. And that's why I think we saw little lesser side effects with medications, and though we saw them, but not as much like growth abnormalities and those kind of issues.
Mm-hmm. Yeah, they did make a point to say that that actually you should ask the patient who knows themselves the best and how relapse of their anxiety disorder is going to affect them and their well-being and the well-being of the
Yeah,
baby. So to really take everything into account and, as we always do, consider risk versus benefit.
that's true. Yes.
Yeah. I think that's the only question that we had. So thank you for that. That was a lengthy article. Um, but
Yeah, thank you.
yeah, very good. And do you have one more article scheduled after this? I have to double check.
No,
This is your last
I,
one?
this is my last one.
Okay, well, thank you for your time with the two articles. And everybody, I did not send an email out this week or last week because I was having some issues with the like server that I'm using or whatever. But just so that you're aware, I do have the Journal Club schedule posted on the new website, Psychiatry Network, etc. Just under events, you'll see a tab that says Facebook Live Journal Club, and I have all the February dates, but I'm adding the March and April dates tonight. So, yeah.
Okay.
All right. Well, thank you. Have a good night, everyone,
Thank
and
you.
thank you, Dr.
Thank you.
Naveed.
Bye.
Okay, bye.
Bye.